Today we're doing a couple of practice questions that may be relevant for the rehab exams. The first question, these are roughly written, C5 AISA with C6 zone of partial preservation, develops autonomic dysreflexia from blocked catheter. There is an autonomic dysreflexia table and you need to list 6 signs and symptoms of AD and write whether they are mediated by sympathetic or parasympathetic system and whether the finding is above or below the level of lesion. So this one is from the New South Wales Agency for Clinical Innovation, and signs and symptoms, there is a list of it right here. And the most common signs, given the question that's been listed, the arrows are the ones that I would pick. So blood pressure is elevated at least 20 millimeters mercury above their usual baseline systolic level. This would be a sympathetic sign, and it is, you'll see it, I've written below the level of lesion. And then pounding headache, which gets worse as the BP rises. This is sympathetic, and you'll see this above the level of lesion because the head is above the level of lesion. Flushing or blotching of the skin or profuse sweating above the level of injury. This would be a parasympathetic response, and you'll see it above the level of lesion. The skin pillow or piloerection, cold peripheries below the level of injury. This is a sympathetic response, and this is below the level. You'll see this below the level of injury. And then other signs include dilated pupils or blurred vision. This is a sympathetic response seen above the level of injury. The next I would choose is bradycardia. Chills without fever is certainly a sign, but it's going to be hard to determine whether it's above or below the injury. It's certainly a sympathetic response, but you'll see it all over. So if the question is phrased that way, maybe I won't write that. And then bradycardia, it's a sympathetic response. You'll see it below the level of lesion, assuming the patient is probably T6 and above. Shortness of breath will be a sympathetic response above the level of lesion, and a sense of apprehension or anxiety is a sympathetic response due to really high blood pressure. And I've written this as above the level of lesion because the person is feeling it in your head. That's how I would answer the question. It certainly gives more than 6 signs and symptoms. So it depends on how the question is written. Okay, and then the next one that's been written here, define zone of partial preservation. I've written it on here. So this definition is from asia.org. So zone of partial preservation happens only in complete injuries, and it refers to those dermatomes and myotomes caudal to the sensory and motor levels that remain partially innervated. Okay, so that's that answer. Next question, list 4 causes of why an IDC might block. I've written sediments, a kinked catheter, bladder stones, blood causing clot retention, and here bladder mucosa obstructing catheter islet. So sometimes the bladder, because there's suction on the catheter, there's suction, from the catheter. So sometimes the bladder mucosa might get sucked into the bladder islet, causing an obstruction. Okay, moving on. INSCI, given 2 years later, list neurological level zone of partial preservation. Only ask for total INSCI and only 1 zone of partial preservation. Not the right and left individually, but they were the same. So apparently the answer was C5 AISA, zone of partial preservation, C7. Next question, patient wants tendon transfer surgery to improve upper limb function, has 3 or 4 wrist extensors, good below elbow flexors, and 0 to 1 below that. So I find this to be a really good reference. I've wrapped the book in my own wrapper. Physical Medicine and Rehab Board Review by Sara J. Cuccurullo. This is the 2nd edition, but there might be further editions. The 4th edition of Board Review is now available. If you're interested in purchasing it, I've left it in a link in the description box below. List 3 things you want to examine for and review prior to consideration of tendon transfer. In the 2nd edition, so the answer is on page 598 and 599. Here are the bits you want to examine. So strength, sensation, range of motion, spasticity. And even up here, we've got behavioral evaluation, because the patient needs to be really compliant after the surgery has been done because they need to immobilize the limb. So I'll leave that for you to read. And then the next question is table asking for donor, muscle, tendon, recipient, the function achieved, and functional effect. Restoring this. 2 examples are needed for 8 points. So in the red book, again, page 599, he's a C5, so brachioradialis to ERCB and deltoid to triceps. You have the answers for C7 as well. C7, C8 on the next page. But here with C5, brachioradialis to ECRB restores wrist extension, improving lifting objects, feeding, grooming, and hygiene. And then deltoid to triceps provides elbow extension, stabilized sitting, transferring, reaching overhead against gravity, grooming, hygiene, pressure relief, writing speed, clarity, and feeding. Does that make sense? Yeah. All right, next question is about post-polio syndrome. Apparently, there's a long stem with history of post-polio syndrome in patient who has just had surgery. Other than that, what is already given in the stem lists the remaining clinical diagnostic criteria or information needed to diagnose PPS, and it's written, they think they've already given it all. So given that I don't have a stem, it's hard for me to answer the question. But based on the Mayo Clinic, in terms of post-polio syndrome, the diagnoses, they must have a previous diagnosis of polio. There's a long interval after recovery, begins at least 15 years after the initial diagnosis, and there is a gradual onset. So the later onset weakness typically occurs in muscles that were affected at the time of initial polio illness. Weakness often isn't noticeable until it interferes with daily activities. You might awaken refreshed but feel exhausted by the early afternoon, tiring after activities that were once easy. Okay. And in terms of this resource, this is Post-Polio Australia, and these are the potential signs and symptoms the patient might experience. So musculoskeletal features, decreased muscle endurance and muscle fatigue, neurological features, new muscle weakness, respiratory features, shortness of breath, bulbar features. But you can take a screenshot and read that yourself. So you can have that. So all that down there. Next question, list 8 disadvantages of a locked knee AFO. I've listed more than 8, so I think it does depend on what the question is exactly. So I've listed more than 8. They can be heavy, they can be bulky, they're restrictive and uncomfortable, they can cause a bit of heat retention so the patient will feel hot, they can be expensive. There's also a high rejection rate associated with KAFOs, up to 60%. It requires manual unlocking, and there is a compensated inefficient gait due to the knee fixed in extension. The gait can be not cosmetic. There's a risk of friction injury to the skin, and potentially it can increase muscle atrophy. So I'll let you decide which 8 is the best to put in. Okay, you can have this, yeah. Next question, list 6 biomechanical determinants of gait in this patient. I assume I don't know if there's a video, maybe not, but in terms of what I might expect. So I wrote out 7, so hip hitching, circumduction, the initial contact might be with foot flat, there might be foot drop, there'll be knee hyperextension, increased lateral trunk sway, and reduced arm swing. This is assuming the person is walking without any orthotics and their polio is unilateral. So that's what I assume. Next question. List 3 signs and symptoms related to muscles you would expect in post-polio syndrome. I mean, it's a lower motor neuron injury, so I just wrote reduced power, fasciculations, and hyporeflexia. Yeah, and I guess atrophy can be in there as well. Yeah. Okay, keep going, there's more questions. You get given a table of patients with lower limb muscle strength. Given a table of the patient's lower limb muscle strength. Define step length and stride length. So step length is the distance between the point of initial contact of one foot and the point of initial contact of the opposite foot, whereas stride length is the distance between the previous heel strike of one foot and the new heel strike of the same foot. Okay, so right foot to right foot, left foot to left foot. That is what stride length is. Here we've got list 3 cardinal features of delirium. I wrote confusion, fluctuating consciousness, and disorientation. 2 exercise principles when prescribing for aerobic exercise in this patient. This is the answer I would give, but feel free to check with your friendly exercise physiologist. I would write, avoid overusing muscles and joints and attempting to exercise beyond the point of pain and fatigue. Regular moderate intensity exercises, for example, every second day to maintain muscle condition. And 2 physiological effects of aerobic exercise in this patient. Again, check with your friendly EP. Increasing VO2 max, increasing cardiac stroke volume. And there is some details of this in the Red Book on page 630. So here it is listed the cardiovascular effects of conditioning exercises. So you can take a screenshot and have a chat to your EP to see which might be the correct answers. Okay.